Mexico. And we alternate between endoscopy and surgery and everything else. But this week is pediatrics, and we're very lucky to have Marisa Beretta with us today, talking about improving access to liver transplantation, which is a subject close to all of our hearts. I do see we're still a bit thin on the ground, but I'm hoping people will continue to enter the meeting. And so by way of introduction, let me tell you that Marisa is a peds hepatologist who works at a Donald Gordon Medical Center, which is one of the 2 sites where liver transplantations in South Africa are done. And she's been instrumental in helping us getting our kids transplanted. So Marisa, thank you so much for coming on today. We look forward to your talk, but also to ongoing collaboration and improving access to for our kids for liver transplantation. Thank you so much. You can take it away.
Thank you very much for the introduction, Tim. Let's get this going. So for those of you who are not aware of where I come from, this is my home base. It's the Wits University Donald Gordon Medical Center. It's the home of our pediatric liver transplant unit. It's a place that is very close to our hearts, as you can imagine, and it's something that we are very, very passionate about. I have no disclaimers. In terms of our agenda, we're going to be discussing global and African perspectives on transplant, as well as challenges to access. We're going to briefly touch on donation in South Africa and issues with donation in this country. Then on to the most important aspects, which are expanding the donor pool, and lastly, reducing waitlist mortality. In terms of our global perspective, pediatric liver transplantation is a life-saving and preferred therapeutic modality for end-stage liver dysfunction. More than 16,000 children under the age of 15 years died of end-stage liver disease in as recent a year as 2017. In 2022, about 3,000 liver transplants in children were performed, the majority of which were actually in upper to middle-income countries, and the rest in high-income countries, with only a marginal amount, 9.1%, in lower middle-income countries. The 10 and 15-year survival rates of these transplants are now approaching 80%, so we're getting good outcomes, and biliary atresia remains the most common indication for transplant, with the majority of those transplants occurring in children under the age of 5 years and under the weight of 10 kilograms. So looking at the global perspective, demand has completely outstripped supply. So recently, innovations are aimed at increasing the usable deceased donors or finding alternative donor sources, because in addition to not having enough supply, we are also having an increased recipient pool as the indications for transplant grow. So looking at what we have available in the literature with respect to the African perspective, you can see that that tiny, tiny little pie there, that piece of pie is the African experience. So we account for approximately only 1% of transplant activity. So this was published this year in 2023. And it said that on the African continent, there is only 2 centers that are responsible for transplant, one in Egypt and one in South Africa. And this highlights the importance of getting your experience out there, because there are in fact 2 centers in South Africa, one in Cape Town and one in Johannesburg, which actually perform pediatric liver transplants. So unless you get your information out there, this is not being recorded and not being recognized in the international community. Living donation is highly prevalent in Asia and Africa, with a higher proportion actually in low to middle income countries, where they are performing more than 25 living donor transplants per year over the last 5 years. And this is because patients in these countries are referred in late stages of their disease process, and waiting for a deceased donor actually carries a high mortality risk. So they resort to alternative measures such as living donation. Whereas whole grafts dominate the North American and split and reduce the Australian Oceania experience. Training centers were found to have been performing more transplants, and in Africa, the ones that were recorded both offered training opportunities. Just in terms of a visual mapping of transplant activity, you can see on the tip of Africa, there we are with our little experience, and then way up north and absolutely nothing in between that is supplying the African continent. Just bear in mind, I think it highlights being said again, that's 1% of transplant activity serving 16.7% of the world's population. So already an inequity is displayed here. So what are the challenges? So challenges in Africa is that, well, the only documented activity for liver transplantation is Egypt and South Africa. And of those two, only South Africa can actually perform related living donation. That results in parents from Africa seeking transplantation from abroad, which makes them at risk for no organized or secure follow-up or long-term immunosuppression, as well as at risk of demising from poor adherence, rejection, and complications of immunosuppression because these patients are not being followed up properly. Private centers have been acting as referral centers for neighboring countries, with the most common destinations being India, Pakistan, Tunisia, and ourselves, South Africa. In living donation, though, this is a risk because those patients coming from other countries, there is inadequate oversight in determining the relation of living donors to the recipient. So what are the prerequisites for an organ transplantation program? So you need regulatory and ethical considerations, you need organ procurement organizations, it's essential to have a good healthcare infrastructure, you need a well-coordinated and dedicated multidisciplinary transplant team, clinical protocols for pre- and post-transplant management, and age-appropriate drug formulation and monitoring, and importantly, funding. So there is an essential need to develop formal government referral systems or national transplant services. So we need support from the national department. You can get twinning with a more established center, like a mentoring system that can help launch a transplant program. You can also get a visiting surgeon who may initiate development, but problems arise with the long-term follow-up and sustainability of those programs, because you also need a commitment to lifelong care. Once you've transplanted these patients, you have committed to looking after them for the rest of their lives, and they need access to the immunosuppression that they are going to need for the rest of their lives. In addition, you need multiple specialties that are required, and you need ongoing training in all areas of your multidisciplinary cohort. So funding is absolutely essential. State funding is almost an absolute necessity for equitable access because it demands expensive resources, it's costly expenditure, it's even higher in children because they have prolonged ICU and hospital stays, an increased number of post-transplant admissions. And unfortunately, African countries have limited resources. And because they're limited, you need responsible stewardship with limited budgets. Because the most common causes of childhood mortality in Africa are your neonatal disorders, preventable infections, and malnutrition. So unfortunately, transplant is therefore a low priority. It's not also appropriate that every country in Africa should have its own transplant program, but countries that have the capacity should be supported and act as referral centers. The biggest obstacle, or let me say one of the major obstacles, is a cost of long-term immunosuppression. So some proposed solutions to this is to lobby pharmaceutical companies for access to affordable medication or to explore low-cost generic alternatives. But it's essential that Africa develops transplant to try to curtail this global disparity in transplant activity that is obvious. So just to highlight the fact that although we do have other important aspects of child mortality that need to be addressed, we have made leaps and bounds in terms of addressing them. So if you look at our mortality rate in the age of 1 to 59 months, you can see that curve is on, well, mostly a decline. There seems to have been a bit of a speed bump there around 2005, but otherwise the overall trend is on a downward. In addition, our under 5 deaths are following the same trend, as well as our 5 to 14-year-old mortality rate. So overall, we are making good progress in reducing our mortality rate. So it might well be time to start concentrating on other avenues, such as transplantation. So what kind of access do we have? So this is just a representation of adult transplantation programs available in South Africa. And you see a clustering around Cape Town, a clustering around Joburg, Pretoria, a little bit there in the middle, Bloemfontein, and then on the coast in Durban. What's marked is if you look at the pediatric, that opportunity in Bloemfontein and Durban disappears, and suddenly you only have access in the Pretoria, Joburg area and in the Cape Town region. In addition, you can see a lot of centers have dropped away. We've only got 2 centers that offer liver transplantation, 1 offering heart or lung, and 3 that are offering kidney transplantation. So I'm sure you've noticed the difference. And this is important because everyone in between is having to get their access at these 2 points. In addition, this is important to us because, as mentioned, as I will mention, adult transplantation programs can be the foundation for expanding into pediatric transplant programs. So how do you establish a center? So national government support is required. You need your multidisciplinary team. You need sharing of resources. Twinning, as I mentioned, can be a benefit in terms of pairing with an established center. Public-private partnerships, such as the one we have, can be of absolute necessity, and essential securing access to lifelong care and medication. At the institutional level, you need a tertiary hospital that's capable of complex surgery. The pediatric programs are often integrated into adult programs with sharing of skills between adult and pediatrics. And also to be available when you transition the patients, because this is lifelong care. You need self-sustained ICU and designated post-transplant care wards with outpatient clinics, an interventional radiology service, specialist services, laboratory, blood bank and tissue immunology, as well as an antimicrobial stewardship program. For a successful deceased donor program, you need an established healthcare infrastructure, extensive healthcare coverage for the population, and a mature system of organ allocation. So how far are we in terms of achieving these? And you can see we've made good ground. At the institutional level, at Donald Gordon, we meet all requirements. In terms of establishing centers, we're almost there, except our biggest problem is we do not have national government support. And that's also reflected in our problems achieving successful deceased donor programs, because you can see that we do not have the infrastructure or the coverage to establish a mature system of organ allocation and transplantation. Essential to this whole process, of course, is also one of your key members of the team is your transplant surgeon and the training thereof. So unfortunately, there isn't much consensus on what is exactly good training. So for example, now in the US, they are leaning towards the requirements for primary pediatric liver transplant designation to be that of a surgeon who has performed at least 15 transplants, 6 of which must be on children under 6 years of age and weight of 25 kilograms. They do agree that there's a minimum number of cases required to ensure competence, but this is not published guidance. There's also an agreement that there should be transfer of skills and knowledge to younger generations so that you can get that experience passed down in a mentorship relationship, and that techniques need to be taught so that they are available, like monosegment and splitting. But unfortunately, while this has benefits in terms of ensuring that your surgeons are well trained and can offer all techniques, the problem is that it can inadvertently also shrink the geographic availability of transplant by reducing the number of centers at which pediatric transplantation can actually occur. So in South Africa, South Africa and Africa, we have a few other additional barriers and problems. So with regards to recipient specific, we often get late referrals, so it's last resorts, which result in lower transplantation rates. Our patients are often malnourished with severe failure to thrive. They often have multi-organ involvement, and they need intensive medical and nutritional support while awaiting transplant. In addition, there are also social stresses, which is our unemployment rate, which is significant, with a dependency on social grants. A lot of these patients, the families of these patients are dependent either on the social grants of the children, or they have other dependents that require them for a living. There's no amenity access and no food security. We have a high infectious disease burden with TB, hepatitis B and HIV, malaria, and parasitic infections. There's a risk of transmission from the donor with both infection and reactivation in the recipient. We are endemic areas for TB, hepatitis B, CMV, and EBV, which all confer a risk in transplantation. And post-transplant infectious complications contribute significantly to morbidity and mortality in Africa. And another important aspect which I've touched on is distance to center. So what level of care is available at their nearest medical center? Do they have access to early diagnosis and referral? This leads into the late referrals and advanced disease that is seen pre-transplant. Distance to the local clinics, the district hospital, or the tertiary center incurs travel costs to families, and they don't even have a good financial standing at the beginning. A lot of them require temporary relocation in order to accommodate transplant at the centers. And some of them, they may not have access to 24-hour medical facilities back home. They do not have access to post-transplant clinic or dedicated medical caregivers even. So they need to identify a contact person at a referral institution with good communication routes, which can be very difficult to establish. Another issue is our paucity of data. And this is reflecting in the fact that I've presented published data, which does not even reflect how many centers we actually have active in South Africa. So the importance of data is that we need to report center volumes, graft and patient survival. We need national collection and international sharing, and maintaining of a good quality program and evaluating performance is integral to this service. The other aspect is that we need to establish our burden of end-stage liver disease. So we need local epidemiology and statistics that can support our motivations for our projected number of annual transplants that we need. So without even being able to provide an idea of how many transplants are needed, it's difficult to motivate to expand the current programs. But unfortunately, we have no comprehensive registries. So there's a couple of very good ones globally. So there's the European Liver Transplant Registry, which is 175 European centers, the Japanese Liver Transplantation Society, which includes 67 centers, and Split, which involves 39 North American centers. We do not have anything of this nature. The problem is that a lot of the registries only include centers from high-income countries. This results in no documentation of the work that's being performed in our country. And it's important to establish donor and recipient registries for basically an objective advocacy for transplantation and to present our outcomes to the international community. And then I just want to highlight another specific risk, or let's say challenge we have in Africa, and that is an undocumented migrant population. So if you look at the top table, that is the estimated number of migrants in South Africa, and at the bottom table is actually the registered number of migrants in South Africa. And that is a huge difference. That is a population of 2 million. That's a third of the population of New Zealand that is missing. So these are unregistered migrants, and these people have absolutely no access to medical care. So that is a challenge specific to our country and shared amongst Africa and of significant burden. So what about donation in South Africa itself? So we have approximately 5,000 South African adults and children waiting for organ transplantation. In South Africa in 2019, we did 356 solid organ transplants, of which 54 adult livers were performed and 34 pediatric, and 20, so almost 2/3 of that, were live related. We've got one of the poorest, lowest deceased donation rates in the world. So we have less than 3 per million population. And unfortunately, the organs we procured have an increased discard rate because a lot of them come from what we call our extended criteria donors. That's because our access to brain-dead heart-beating donors is actually limited because of religious and cultural belief, lack of recognition of brain death, and lack of support from medical staff and hospital administrators. Unfortunately, we have no organized network for organ sharing, and frequently state and private programs are actually competing for donors. There's a lack of prompt identification of those potential donors because there's no mandatory training of healthcare professionals in that respect. We have lack of timely notification of procurement agencies with either late or no referrals, and there's no mandated referral policy, so it's left at the discretion of the attending physician. In addition, we have poor potential donor management with de-escalation of care before the family are even approached, and then poor timing or non-designated family approach when they are approached before they have come to terms or by an untrained individual. So all of these impact negatively on our ability to acquire donors. So touching briefly on our reasons for low donation rates. So we have cultural and religious beliefs, public and healthcare provider lack of awareness and poor understanding of brain death, current South African legislature, which does not adequately support deceased donation, and healthcare prioritization and policy making. So cultural and religious beliefs are often stated as one of the main reasons for poor donation rates. This includes family preference of keeping deceased person's body intact or buried within a certain time frame, but it also touches on lack of trust in the medical fraternity, with transplantation efforts perceived as purely for profit. Another problem is not knowing the deceased wishes, and less of a factor compared, while cultural and religious beliefs are actually believed to be less of a factor compared to lack of awareness. There's actually no religion or culture that is not in favor of assisting a person in need or prohibiting the acceptance of an organ when needed, because religions traditionally perceived as opposed to donation, specifically Judaism and Islam, have had religious scholars state support of organ transplantation in recent years. So what about lack of awareness and poor understanding of brain death? So it's a difficult concept to accept that brain death is equivalent to legal death. It's also a state with no potential for recovery, which is not well understood. Procurement in a brain dead patient does not lead to the death of a patient. This is another factor that is not well established. In addition, there is not protocolized management of the brain dead individual who is a potential organ donor. So it's not incorporated formally into end-of-life treatment algorithms, and it's not taught formally as a component of any training syllabus at any level of healthcare provision. Every family of a brain dead patient should deserve the opportunity to consider organ donation in an appropriately enabling environment. So this is something that we as health professions need to concentrate on. South African legislation is also a role player in our low donation rates. So our legislation is very clear on the absolute prohibition of organ trafficking and exploitation of vulnerable populations to promote organ donation, and the prohibition of organs for sale. It also is clear on the requirements of brain death declaration being independent of the transplant team, but it's less clear on how to balance the wishes of the patient and of the family. The written consent by a competent adult prior to death is actually not sufficient, and consent from the family is required. There's no mandated referral of brain dead patients to the organ transplant team, and no mandated auditing of end-of-life decision-making and care of medical teams. And these are all essential in growing your deceased organ donor programs. Our South African government also rightly prioritizes primary healthcare interventions to alleviate the burden of disease because of the continuous resource constraints that we have. In addition, when we get to donation and our potential donors, this requires allocation of beds to these patients instead of potentially salvageable patients. So that is an additional pressure on our resources. Transplantation is not prioritized as a major healthcare need, but it is a cost-effective modality of treating end-stage organ failure, and it should not be neglected. And looking at those graphs that I showed earlier, you can see that we have made significant headway in terms of addressing some of our primary healthcare problems, and it might well be the time to concentrate on things such as transplant at this time, and it should actually be used as a measurable healthcare outcome. So how do we expand the donor pool? So we can expand both our deceased pool and our deceased through the use of extended criteria donors, ex vivo perfusion, and the technique of split liver transplantation, and living through paired exchange, organ donor chains, and domino transplantation. And then across both board, deceased and living, we can offer ABOI, so ABOI incompatible transplantation. Split and living are both surgical techniques that need to be taught to a team and practiced in order to become available. But let's start from our deceased pool, our extended criteria organs. So the problem is that some people write off an organ before even offering it, and units are encouraged to refer all potential organ donors, irrespective of their perceived medical suitability. And this is because urgent cases on the waiting list will have significant survival benefit from an extended criteria donor organ compared to absolutely no transplant at all. And these days, with the advent of ex vivo machine perfusion, complications can be offset by using the machine perfusion to improve the quality of these extended criteria organs. The reason this has become necessary is because the world in general has an aging population with a longer life expectancy and a rising rate of metabolic conditions. And this has resulted in a decrease in donor utilization rates from 78% to 44%. So that's a huge amount of organs that are no longer being deemed suitable for transplantation. So we need to increase our use of marginal organs, but these are susceptible to ischemic and reperfusion injuries and are at risk of delayed or compromised graft function and rejection. One of the biggest problems is that there's actually no universally accepted definition of what is an extended criteria organ. But broad categories to describe extended criteria organs is basically one in which the organs are not pristine. So it involves donation after cardiac death organs, HIV-infected donors, hepatitis-infected donors, elderly donors, those organs with a prolonged cold ischemic time of more than 12 hours, and steatotic livers with more than 30% macrosteatosis. So DCD is becoming a big thing, and that's because of the fact that it's a rapidly growing source of organs. If you can keep your warm ischemia time less than 30 minutes in patients under the age of 50 years and limit your cold ischemia time, this is a huge avenue for expanding your pool. Organs, however, suffer unpredictable warm ischemic damage, and the grafts are at high risk of ischemic biliary complications, hepatic artery stenosis, and graft failure. We have two arenas of DCD. So there's controlled and uncontrolled. So controlled DCD is withdrawal of life support in a patient not brain dead, but deemed to have a very poor prognosis or no potential for quality of life, in which care is withdrawn in the theatre setting, completely independent of the transplant team. Once circulatory death has been established, there is rapid procurement of the organs. And uncontrolled DCD is procurement of organs from patients who die following unsuccessful resuscitation from an in or out of hospital cardiac arrest. And the legislation for DCD differs widely across the world. And this is reflected in, you can see that it is prohibited in Germany. So there's an absolute moratorium on it. It's not permitted. And then there are wide differences in the time, what's called the no-touch time, in which you are not allowed to procure after declaration of death. So you can see it ranges between 2 to 5 minutes in most countries to as long as 20 minutes in Italy. So although this is an arena that is in evolution, it has a lot of potential. But it has also introduced the idea of intensive care to facilitate organ donation. And that's the initiation of life-sustaining therapies in patients considered to have a futile prognosis, with the intention of incorporating organ donation into the end-of-life plans. So this is elective, non-therapeutic ventilation, hemodynamic support, and monitoring in an ICU setting. And this is a stress on limited resources, especially ones such as our ICUs. Hepatitis C was initially a moratorium on donation, except for status 1 high risk or Hep C positive recipients. There was high rates of transmission post-transplantation with acute transaminitis and late chronic liver disease, including fibrosing cholestatic hepatitis in patients. Cirrhosis occurred and was aggressive. Chronic hepatitis C infection was also associated with accelerated atherosclerosis and a reduced life expectancy, and it was influenced by donor viral load and post-transplant immunosuppression. but we have had a lot of advancement in this arena, and now we can detect specific genotypes. There is safe and effective antiviral therapy that's available, well tolerated, highly efficacious, and potentially curative. So use of Hep B, C antibody positive, but NAT negative patients donors is encouraged, and there's still a significant survival benefit over remaining on the waiting list. But the one caveat is that antivirals must be available. Hep B, we've always used our anti-Hep B core donors because antiviral prophylaxis is available. However, you do need to place those patients, those recipients, on indefinite antiviral therapy, with entecavir and tenofovir being preferred. But the new caveat is that we are considering the use of Hep B surface antigen livers, although not as well established. There have been incidental transplants, and they have had acceptable 3 to 5 year survival rates. There must be a complete absence of Hep D co-infection, though, because there is no effective way in which to prevent Hep D infection by antivirals, and it is an infection that can be rapidly progressive. But it is a possible avenue for consideration, and it is something that is being actively explored. And then we get to HIV. So the transplantation of HIV-infected organs has always been accepted as a therapeutic modality in HIV-infected patients. These days, we have highly effective antiviral therapy, so it has basically turned into a long-term manageable disease. They are showing equivalent outcomes to non-infected organs in liver and kidney transplantation, and it was legalized in the US by the HIV Organ Policy Equity Act, HOPE, which was actually based on South African data, so our renal transplant data. The HIV-infected patients have a worse prognosis on the waiting list with higher mortality rates, and they are disproportionately affected by organ shortages. Although co-infection with hepatitis C is common, it does complicate post-operative management and is a problem. So the dual infection is an extreme negative impact on the outcome of a recipient. And I mentioned at SATS last year that the Joburg team transplanted a living donor HIV-infected liver graft into an HIV-negative child with good results, and she is still alive and doing well to this day. And then we have organs from the elderly. So the Eurotransplant actually implemented something they called the senior program, where they procured from donors more than 65 years, and these are allocated to recipients more than 65 years. And the reason they did this is because the donor pool was becoming progressively older, with medical causes being the most likely cause of death. And the number of elderly patients on the wait list is increasing because of the fact that we are expanding our recipient pool. And the odds of dying on the waiting list were 5 times higher for patients more than 65 years compared to those less than 50. And discrimination based on the age of the recipient was unethical. So essential to this was the idea that biological age of the organ is actually much more important than chronological age. And this has helped drop the waitlist mortality in a number of European countries, although it is a fact that these patients are known to have higher risk of delayed graft function and rejection. They do have similar odds of graft surviving if our cold ischemic time is minimalized. So at this point in time, they are still only used in the elderly, but there is a movement towards trying to optimize organs to make them available across board. And how so? We do resuscitation of our marginal organs with ex vivo perfusion, and this is exciting. I'm very excited by this. So static cold storage slows but does not stop graft metabolism. So marginal quality organs, which would otherwise have been discarded, can now be resuscitated with machine perfusion prior to implantation. So our ex vivo perfusion allows for assessment of our graft viability, delipidation of a fatty graft, and it lowers the risk of our non-anastomotic biliary duct strictures, which are quite problematic post-transplant. So the graft is perfused with either normothermic or subnormothermic solution after procurement, which allows nourishment and removal of toxins within the graft. And another further approach is actually to add oxygen to that, and that's named HOPE, hypothermic oxygenated machine perfusion, and the outcomes of that is actually excellent. It's shown to have improved outcomes compared to extended criteria grafts, which just undergo normal static cold storage. And it is likely that although it's expensive, that the cost limitations will be offset by improved outcomes. And then we get to the one that bridges both deceased and living, which is our ABO incompatible. Unfortunately, it's actually really utilized in the rest of the world. So only 5.6% on the OPTN registry have had an ABO-I incompatible transplant. Age has been recognized as an important predictive factor. So those older than 1 year are associated with an increased morbidity and mortality, although the outcomes are on par with compatible, even though they have increased bile duct complications and risk of antibody-mediated rejection. It has been thought to be an essential consideration in infants with a high PULT and in acute liver failure because they carry a high risk of mortality. The aim in ABO incompatible transplant is to reduce ABO isoglutenin titers before transplant, because our titers are predictive of success as the circulating preformed antibodies to the donor blood group actually bind to the graft epithelium, resulting in chronic antibody-mediated rejection. Protocols unfortunately vary markedly from center to center and include rituximab, plasmapheresis, and if you're lucky, immunoadsorption. Local infusion therapy and splenectomy have basically been replaced. So those are no longer in use, although there are some people that might still practice it. And then post-transplant immunosuppression is modified to be dual agent. Our surgical techniques are one of the most important aspects of improving our deceased donation accessibility. So our two techniques are split graft and living graft. So a split graft is a deceased donor liver that's divided into two portions for transplantation. The criteria are required age less than 40 years, transaminase is less than threefold the normal values, and low pressure requirements. It's the main source of liver grafts in children in countries with low living donation rates, and the graft allocation is either child and adult or two adults. Up to 20% of all organs procured from deceased donors are actually suitable for splitting, but right there under our barriers, only less than 1% of liver grafts are actually split. And when they are split, the decision has been prompted by allocating a child as the primary recipient. This is because pristine grafts must be used. They must be able to endure long, colder ischemic times and more biliary complications. It requires expertise to split the graft, and more than one transplantee must be available to transplant concurrently. But this is possible. It requires a paradigm shift, and one of those that could prompt use is a mandated split policy, in which it is required to split every splittable liver. Then living donation, and this is our bread and butter. So this is actually the important, I would like to highlight this, it cannot be highlighted enough. We actually get superior results in living donation. So not equal to, but actually superior to deceased donation. Why? Because you can transplant them before they develop significant morbidity. Graft survival is extended because of superior organ quality, shorter cold ischemic time, and no deleterious physiological sequelae associated with brain death. It does require separation of care between the adult donor and child recipient, and expertise in both the operation and post-donation follow-up. And one that's quite exciting and not used here because we are not at that stage yet is altruistic non-directed donors that are acquired through social and media appeals, although strong ethical foundations are required to that. However, we do have barriers, and those include general mistrust of the medical community. So it's the fact that most people will avoid seeking out unnecessary surgery, limited social networks or individuals of the family that they feel comfortable approaching. So there's only a limited number of individuals that they are willing to ask. Social financial limitations on the ability to volunteer. So the parent who would like to volunteer but just cannot afford to. It is associated with an increased financial burden on the donor for both the event and potential extended convalescent. There is a learning curve required to achieve good outcomes. So you're not going to get good outcomes straight from the start of a program, and you need high volumes to maintain good quality programs. So there is documentation of increased complications in those centers performing less than 40 per year. So a high volume is required to get good results. And national policies need to support living donation, and you get variable support at an institutional level. So you need to have national and institutional buy-in to a living donation program. And just to highlight the fact that even in the US, patients on public insurance are half as likely to get a living donor than those in private. And this translates into our experience as well. So you can see in 2021, the majority of practice was private RLD, followed by state RLD. And this did not get better. In 2022, it actually got worse, with state RLD only accounting for 18% of our practice. And in the US, they analyzed some of the factors, and they found that insurance income and sociodemographic barriers contributed to delay. So public insurance was actually a proxy for low socioeconomic status. And this might well translate into our environment as well. There's increased environmental stress, there's increased social barriers, and a lower health literacy with less comfort navigating the healthcare environment. And I think these are all things that could well be applicable in our environment. So liver transplant patients also need increased financial support. And in the rest of the world, they get these from organ-specific disease organizations, fundraising options, and social work involvement. And unfortunately, these are all avenues that we don't have well developed in our country. There are a few techniques in related living donation that can help increase accessibility. So there's paired donation, which is where, although the donor cannot give to their related recipient, they could potentially give to someone else, and you could swap the two donors. And then your organ donation chains. However, that requires an altruistic, non-directed donor to start, and then that starts a whole chain of people receiving transplantation. However, you do need to keep the chain going in order for this to be of benefit. And like I mentioned, you do need the altruistic donor to start a chain. So these are all techniques that are employed internationally and help increase your impact of living donation. And then we have donor transplantation, which is where you receive an explanted liver from the recipient of a traditional liver transplant, for which the indication is usually a metabolic condition, a single gene defect that has resulted in, well, a liver that is otherwise structurally normal with normal function. It's usually a disorder in which the liver enzyme deficiency can actually be compensated for by the systemic presence of sufficient enzyme, and the metabolic disorder of the donor, therefore, does not manifest in the recipient. So in our experience in terms of pediatric, the most common is actually maple syrup urine disease. So the rest of the body produces enough enzyme to compensate the offset of the liver that is no longer producing. And in adults, they actually have experience with adenomatous polyposis. But I would like to highlight a very important player in this, and that's the power of social media. So Kumar et al. In the US implemented a mobile application which created a platform in which to post experience with organ failure and the need for a live donor. And the people who used this were 6.6 times more likely to have a donor. And we have a few social media outlets for ourselves in which we could encourage live donation and improvement in our deceased donation rate. And that includes TEL, which is a non-for-profit that promotes informing friends, family, and making it known that you are an organ donor, and as well as a new initiative called Save 7, which is an attempt to do the same, notify friends and family of your registration as an organ donor, in which to improve the odds of your organs actually being used post brain dead status. I would like to highlight this area in TEL's website, and this is for medical professionals, and you click on find the contact list, and it gives you access to all the organ procurement, your transplant coordinators around the country, which makes it easy for you to contact your transplant coordinator. And if we could start using these platforms, we could dramatically increase the social impact of organ transplantation and access to organ transplantation. Then I go on to my novel ideas, which I'm going to touch on very briefly. So there are a few de novo ideas out there, and they are all in evolution. So it includes the reuse of auxiliary livers, liver regeneration with three-way sharing and xenotransplantation, and bioengineered livers. So auxiliary livers are livers that are used in acute liver failure, which accounts for 10% of liver transplants. They are grafts that come from both living and deceased donors, and they are segments of liver that have been implanted adjacent to a native liver as an in vivo bridging therapy when the native liver recovers. So what they are doing in the Netherlands is they are successfully reusing auxiliary liver grafts after they have regenerated in the original recipient and the native liver has recovered. The feasibility, however, depends on the in vivo graft regeneration, the integrity of the graft after removal, and the absence of any rejection. Liver regeneration with three-way sharing is an ex vivo technique in which you remove the liver, divide it into three, allow all three segments to regenerate, and then implant those three regenerated sections into individual people. It is very experimental, but has great potential, as essentially one liver would then give rise to three. And xenotransplantation is obviously where you take an organ from an animal and transplant it into a human. Pigs are regarded as the ideal donor, with the main barrier being basically life-threatening thrombocytopenia and uncontrolled coagulation dysregulation. So there's a lot of work going on with CRISPR gene editing. The first xenotransplant conducted was a heart transplant, and they've subsequently conducted a kidney transplant, but this is all still very, very experimental, and zoonotic disease is a major concern and was actually responsible for failure of the first xenotransplant, which was a heart. And then bioengineered livers are an interesting idea, which is basically starting from scratch. So you create a scaffold, you populate that scaffold with liver cells, and then you essentially have yourself a de novo liver. The cost is exorbitant. So essentially it started off at $20 million US, and we are now sitting at $10 million US. But optimistically speaking, we know that the first sequencing of the genome cost $300 million, and it's now only $3,000 to $5,000 US. So hopefully bioengineered livers are a feasible option in the long future, not anytime soon, but out there. And then I'm going to touch on reducing waitlist mortality, because we know that we used to have a waitlist mortality of about 20%. We're now down to 8%. Everywhere in the world, it's about 6%. And these are patients who cannot access transplant because they obviously demise before they get the opportunity. There are multiple barriers to listing to begin with. And once listed, there are a number of factors that can negatively impact your chance of surviving. And some of those are not taken into consideration. So allocation policies are actually at the moment not optimally serving children. 8% of children are dying on the wait list in the US. A lot of them are getting listed with exception points, 44%, because of the fact that the PELT is not accurately reflecting the mortality. The risk is thought to be at least 17% more than that calculated by PELT. And actually, UNOS has approved a new recommendation for the use of a PELT creatinine score. And importantly here, there's also ethical consideration. I mean, a society usually prioritizes the health and well-being of children. So it seems to follow that liver transplant should align with these priorities to guarantee the maximum benefit. I would say the ethical principle of fair innings is there as well, because the idea that the children have opportunity and should merit opportunity. But this is a very contentious point in ethics. But importantly, I think, and this is an important consideration, is that if you're going to split a liver, you are actually benefiting two people. You are benefiting the child and the adult. So I'm going to concentrate on the pulse sodium creatinine because I'm hoping this will come into play in the future shortly. So it is a calculation that includes sodium and creatinine. They prospectively applied it to 5,000 listings, and it correctly ordered 5.5% more candidates by risk of mortality at 180 days. And its ability to rank children based on risk of death improved dramatically, although they showed that it requires a shift of almost 10 additional points to equalize a child's mortality risk with age-standardized mortality rate in adults. So that essentially would mean that our children would need an additional 10 points, which the pulse sodium creatinine would reflect, to equalize their mortality risks with their adult counterparts. Other arenas that were found to be contributive to mortality were acute on chronic liver failure, which is poorly characterized, but refers to sequential multi-organ failure in an individual with chronic liver disease. It has a poor prognosis. It's highly fatal with a steep and steady mortality rate from 28 days. It is difficult to differentiate with acute on chronic and decompensated cirrhosis. And the problem is that current allocation system actually does not recognize an increased risk of death in acute on chronic liver failure, and a lot of these patients die on the wait list. So there are a number of movements towards trying to stratify the risk of acute on chronic liver failure and include it in the assessments. Growth failure thresholds. So this is something that I will touch on very briefly because, in fact, we use a different PELT calculator, and we actually ourselves assess growth failure. But if you use the OPTN PELT calculator, the growth parameters actually are not accurately reflected. And the effect of that is that children who are actually failing to thrive are not classified as failing to thrive. And because of that, they lose 6 PELT points. And that impacts heavily on their location in terms of, well, allocation. And the take-home message of this is that all PELT calculators are not equal, and that if we are going to use one, we should use a standardized calculator, one that is more accurately reflective of the effect of growth failure on allocation. Functional status is quite an exciting arena. So for a long time, adults have always had frailty. This is a landscape play performance scale assessment that was conducted also in UNOS in 2005 on all pediatric liver transplant candidates. Unfortunately, it's subjective and there's no validation, but they looked at a significant amount of candidates and they found that 30% of those with severe impairment demised. So the take home of this study was that functional status has significant impact on outcome and waitlist mortality. And we need a measure of functional status in order to detect these patients and properly stratify them in terms of allocation. And then there has been obviously a lot of attention placed on disease-specific waitlist mortality, and biliary atresia, because it's the most common indication, is the one that has most been explored. And there was a few studies. One looked at prioritizing biliary atresia, and what they did is they gave them a MALT of 32. And the effect of that study, or what was observed, was that waitlist mortality actually decreased, not because they got prioritized allocation, but because more living-related transplants were conducted. And that might just have been because the increased MALT prompted the teams to actually prioritize their transplants. So no one was actually disadvantaged, and a lot of these patients actually had good outcomes because of a decreased waitlist time and increased transplant rate. But what was interesting is that they looked at access to care in 219 biliary atresia patients, and they found that Kasai performed at a specialist but non-transplant center happened at an older time for referral, and complications had been experienced and they needed medical support. So priority status was actually needed for 35% of those 219 children that were listed. And that highlighted that networks are needed for timely referral to a transplant center. and possibly centralization of care is essential to make sure that Kasai's are actually performed at a transplant center where they have access to a transplant team in their long-term care. And lastly, distance to center has been explored. And what I'd like to highlight is that they looked at the negative impact of a median distance of 64 miles, which had a negative impact on their waitlist mortality. Because of access to specialist transplant care, they didn't have access to liver transplant centers, and volume actually also impacted the study because of the fact that some of the centers did not have the volume requirements. So I want to highlight the fact that these are our two little epicenters of pediatric transplant, and you can see they're 1,390 kilometers apart, which is significantly more than 64 miles. So I can only extrapolate the fact that there is a significant impact being had on distance on our population in terms of our waitlist mortality. And then sarcopenia is an interesting avenue being explored, and that is being conducted with psoas muscle surface area. And this particular study has found a 4.9 times higher risk of death for every 1 unit decrease in a PMSAZ score. And sarcopenia has definite consideration in adults, and I think it's an avenue that hopefully will become very prevalent in the pediatric population as well, because it is definitely a possibility of a novel indicator of disease severity in pediatrics. So our take homes just for access is that demand outstrips supply. It's a global problem that Africa only accounts for 1% of global transplant, or for global pediatric liver transplant activity, that we have one of the lowest donor rates in the world of less than 3 per million, that multiple factors contribute to poor donation rates, including lack of awareness, education, funding, and policy implementation. Surgical techniques of splitting and live donation can dramatically improve access, that we can improve deceased donor supply through the use of extended criteria organs, DCD organs, and organs that are resuscitated through ex vivo perfusion, that living donation could be improved through increased awareness, education, and financial support, that at the moment, unfortunately, allocation does not optimally serve children because the PULT underestimates the mortality risk by at least 17% because it has not been updated in decades, and that there are a number of variables that contribute to waitlist mortality that are not being included at this point in time in the PULT that could be targeted for intervention and inclusion. Those are my resources, and I would like to thank everyone for the opportunity to talk to you today. Thank you.
Thank you, Marisa. That was an excellent talk. I certainly learned a lot. And yeah, thank you for driving the transplant program, the pediatric transplant program, together with your team, and always being available for our state patients. So I want to just have a look for questions. I had one, and now it's, oh, there we go. So Ola Jumoke is asking, would a patient who received the liver from an HIV patient have to be on heart? You want to tackle that one?
Are you talking about the patient who was HIV negative, who received the HIV positive? Oh, that's what I'm going to assume. So yes, they do need to be on heart. Whether they need to be on lifelong therapy is still being assessed. So at present, there is no evidence that the recipient has contracted HIV, but there is ongoing monitoring at this point, and it is felt that there still needs to be a bit more monitoring before we commit to withdrawing heart therapy.
And are you still doing those at the moment, Marisa?
So during COVID, we shut down that avenue quite dramatically because we felt it was too high risk. We are trying to get it up and going again. We have had the fortune of not having had to resort to this avenue. So we've had the luxury of having alternative donors. So we've not had anyone recently who we feel has been warranted the use of HIV infected into an HIV non-infected recipient.
Potential donor before you go ahead.
Sorry, Tim?
I think my internet is playing up. I'm assuming that you need to first make sure that there isn't another potential donor before you go ahead with that.
Yes.
I see
So
a hand from... Carry on.
So yeah, basically you have to have completely exhausted every avenue. So really, even altruistic, non-related, you have to have completely exhausted absolutely every avenue, and you need to have documented that fact, because you really need to present to each patient, it's got a ethics panel review. So it needs to be confirmed that it is an ethically appropriate action, that you have exhausted every donor, you have actively sought out an alternative donor, and that this is literally the only prospect that is available.
Yeah. Penny Rose has got a question. Do you want to go ahead?
Thanks, Marisa, for a really good talk. I was just wondering, in terms of the current eligibility criteria for transplantation, are there restrictions in terms of nutritional status? So if a child is even moderately malnourished, would that be considered an exclusion or an indication for prioritizing them for transplant?
So what we had found from our previous review of our outcomes is that if they fall below the -2 standard deviation, they need to be completely excluded from transplant. And that's because when we assessed our patients who fell between, well, just below -2 up to -3 standard deviations in terms of their mid-upper arm circumference, we had an 8-fold increase in mortality. So it was unconscionable to offer transplant to those patients beyond that point. So -2 is our cutoff point. We have still found an impact on -2 to -1 standard deviations of the mid-upper arm circumference. So there is a risks and an odds ratio there as well, unfortunately. So the crux of it is, the better your nutrition, the better your outcomes. So the closer you can get these patients to nutritionally robust, the better. If you don't, then you carry increased risk. The only ones that we are completely precluding from transplant are those below -2. So above that, we are still doing, but it is with the knowledge that the closer you are to -2, the worse your outcome is going to be. So at this point in time, we haven't incorporated that into a protocol per se, but if it's a sustained observation, then we might need to consider modifying that as well.
Yeah, thanks, Marisa. I think it certainly highlights how important early and aggressive nutritional therapy is in these children. There's a question saying, Joanna, saying, thanks for the great presentation. How many times can you retransplant a child who may require it? And what is your experience with this? Okay,
so we've never gone beyond 2. But that's because we're a young program. So the 2 that the dual transplants that we do are usually for complications like primary graft dysfunction or hepatic artery thrombosis. So we have quite a few patients in our unit now who have had 2 transplants. We have not had to yet go to 3, but I know that there are patients who have been considered for listing for number 3 in the young adult range. So those are patients who have had the misfortune of having 2 transplants when they were younger and now approaching the point where they are having long-term complications of their graft and they need a 3rd. So the answer internationally is 6. So there's up to 6 retransplants done internationally. So it reflects your quality of your surgeons as well. Not quality, let me say your experience of your surgeons. So your more experienced centers are capable of offering even more numbers of retransplants. The reason being is because your survival rate with every transplant drops because of your complication rate going up. So really it depends on the indication and the individual that's being assessed. But at this point in time, there is no like moratorium, let me say, on going beyond 3 transplants. So we've done up to 2, and that's only because we've needed up to 2. I don't anticipate that a 3rd would be turned down, though, at this point.
Okay, thank you. I don't see any more questions at the moment, no hands that I can see, and we are a little bit over time. So if anyone still has questions, they better raise their hand now or type it in. In the meanwhile, I want to say again, thank you so much, Marisa. Excellent talk, excellent public-private partnership that we are very pleased to have available to us. Thanks also to the iEcho New Mexico team and the iEcho India team for their technical support. The recordings will be available on the Gastro Foundation website, and thank you to them and to their sponsors. And yeah, I think other than that, there were lots of people saying thumbs up, clapping, and great talk. So thank you very much, Marisa.
Thank you.
Next week is a public holiday in South Africa, so we won't have Gecko next Wednesday, but I do hope to see many of you at the SAGES conference in Pretoria, and the week after that we'll be back, and it will be about cellular carcinoma's turn to present. So thank you very much. Have a good afternoon, evening, and see you again.